Welcome everybody. I'm Elizabeth Moore. I'm the Coordinator General from the Office for Mental Health and Wellbeing. And this is the first in what we hope is a series of international lecturers coming to discuss issues of grave importance to all of the Canberra community. I'd like to start by formally acknowledging the traditional owners of the land on which we meet, the Ngunnawal people, and pay our respects to their elders past and present. I would also like to extend that acknowledgement to the lands on which you are viewing us from. So Yuma Lundi. It's my privilege to introduce Professor Helen Killaspy, but before I do, I'd like to do a little bit of housekeeping. There will be a question and answer series on the screen, and please don't hesitate to put your questions down, and Helen will answer them at the end of the session. Prof. Luis Salvador Carrillo, who is our collaborator in this venture, will be doing the wrap-up at the end of this session, which is due to last for about 1.5 hours. This particular session has been supported by the ANU Policy Greenhouse Fund, and it is part of, I hope, what will be an ongoing collaboration between ANU and the Office for Mental Health and Wellbeing. Professor Helen Killaspy is known to many of you. She is an international leader in rehabilitation psychiatry and works with complex patients in systemic ways. I will have to read this very small print now because we have no light. She is Professor and Honorary Consultant of Rehabilitation Psychiatry at University College London and Camden and Islington National Health Service Foundation Trust in the UK. She leads national and international programs of research that focus on the assessment of quality of care for people with complex mental health problems and the evaluation of complex interventions for this group. Please would you join me in welcoming Professor Helen Killaspy.
Thank you very much indeed, Elizabeth, for that introduction, and thank you all the participants who've tuned in these rather strange times that we find ourselves in. And just to say thank you as well to Lewis for the invitation to come and to be here in Canberra. I'm going to be talking to not about COVID-19, so I hope in some ways my talk is a bit of light relief from what you're hearing every day in media. And the title of my talk is Enabling Recovery for People with Complex Psychosis. So just to begin, I want to tell you a little bit about what we mean by that term complex psychosis. Well, we now know from the longer term studies of people who are developing some form of psychosis, such as schizophrenia, for the first time, that around 15 to 25% or so will go on to develop complex problems. And that finding has been replicated a number of times now. And by that we mean people who have symptoms that are not responding well to first or second or even third line treatments, both positive symptoms, but also the negative symptoms that come with longer term psychosis. Alongside that, we're talking about the cognitive impairments that can coexist when people develop psychosis, things that particularly impact on people's ability to organise themselves, the executive functioning parts of the brain. And similarly, coexisting problems that may have pre-existed the development of the psychosis, for example, pre-existing intellectual disability, developmental disorders such as those on the autism spectrum, and trauma attachment problems. And then alongside all of that, physical health comorbidities are highly prevalent in this group, as well as other mental health symptoms aside from the psychosis, anxiety, obsessive compulsive disorder, etc. And substance misuse can also be a prevalent problem. So all of these things come together into a kind of a confluence of complexity that makes it very difficult for the person to manage their everyday tasks. So, for example, managing to plan their day, to get out of bed, to do their self-care, their shopping, their cleaning, their budgeting. And their interpersonal skills may also be affected, which can then impact on their ability to keep relationships going and also to access the community and take part in society. These problems also leave this particular group highly vulnerable to self-neglect. In our studies in England, where we've looked at large numbers of people who have complex problems like this, we find that a very high proportion are vulnerable to self-neglect, up to 3/4. And there's also a very high prevalence of people being vulnerable to exploitation from others, up to 41%. So because of all of these issues, this group tend to spend long periods either in hospital or on leaving hospital to be requiring very high levels of support in the community. And because of that, they tend to absorb a large proportion of the total spend on mental health. In the UK, services that focus on people with complex psychosis are referred to as mental health rehabilitation services. And you see on the slide that I'm just showing here is a definition of contemporary rehabilitation at the top of the slide. And that definition, although my name is against it, is not my definition. It's a definition that's been collated from the responses to a survey of rehabilitation practitioners about what they thought mental health rehabilitation was all about. And the things that they stressed were that rehabilitation was a whole system approach. It wasn't something that you do to somebody in an inpatient rehabilitation unit, for example. It was actually a process that involves a number of different components of care coming together, often organised into a care pathway to support the person to be able to build on their strengths and to overcome some of the difficulties that I've just described in order to be able to live successfully in the community. Now, those components of that pathway include inpatient and community services. About 80% of people who come into this pathway in the UK will come in directly from an acute mental health admission ward, but about 20% come from a forensic unit. So these services, rehabilitation services, provide an important exit route for people who are leaving secure care. They spend time in the specialist inpatient or community rehabilitation unit before then progressing to the community, and most will move into some form of mental health supported accommodation and over time graduate from higher to lower support. The clinical input being provided into supported accommodation by community mental health teams, often community rehabilitation teams, and physical health care being provided by primary care services in the same way as it would be for any member of the public. The specialist things that go on in rehabilitation services have been summarised in the document that I've just put up on the slide. This is a guide for commissioners of these services, and so it's quite a useful reference, and it's free to download if people want to do so. And it talks in that document about the need for there to be specialists who understand how to assess and decide on the complex medications that people with complex psychosis may require. And when you get into complex medication regimes, you get into complex side effect management too. So psychiatrists who are specialists in rehabilitation are specialists in those aspects, but they're also very aware of the physical health comorbidities that this group may experience and able to assess, but also to make appropriate referrals to deal with those. The big focus in mental health rehabilitation, though, is mainly about function. It's about trying to stabilise symptoms and help people to gain the highest level of function so that they can be able to move beyond an inpatient setting and to be able to move on to the highest level of independent living in the community that's possible. And so occupational therapists are key to rehabilitation services. They, of course, have a focus on activities of daily living, but also helping people to engage with community activities. The whole team will be involved in assessing and delivering evidence-based psychosocial interventions, but also there's a specific role for psychologists, but not just in delivering the interventions, also supervising other staff and also providing forums, facilitating forums for the staff team to be able to reflect on what's going on within the team, the difficulties they may be having in helping somebody to overcome their problems. How do we engage someone who is showing having some difficulties engaging with the supports that are available? So that reflective practice component is really key to rehabilitation services, and I think particularly important because when we think about all of the problems that this particular group may have, it's often the case that there has been a sense of therapeutic pessimism for them elsewhere in the mental health system. And it's also the case that sometimes through the course of many years of illness, they may have become estranged from family. So it's very important that the rehabilitation practitioners don't feel that. They actually feel optimistic about the work that they're doing and the fact that it's going to be able to support people to be able to progress and get better. That takes some time though. So those staff working in rehabilitation services have to know that they're going to see incremental improvements, small steps, rather than very large leaps. And you can get a sense of that when you look at the timeframes associated with the components of care in the pathway. We know that from our research, we know that people who are coming into rehabilitation services have often been unwell for over 10 years before they get to a rehabilitation service and have had many admissions during that 10-year period. That period is too long, and we need to be better at identifying the people who need rehabilitation services earlier. Once in the rehabilitation inpatient unit or community-based rehabilitation unit, people will often require somewhere between 1 and 3 years of specialist intervention before they are able to progress into the community. And it can then be a number of years, often over 5 or so, before people are able to progress to the highest level of independence. So when you put all that together, you can see it's a very long trajectory. And therefore, staff working in these services need to hold on to that long-term view throughout the treatment of the person, the support that they're delivering to that person, no matter where they're working within the pathway. So everybody's holding on to this idea of a long-term view for the individual. And the idea of the whole pathway is about maximising and optimising people's autonomy. Now, there's now a number of studies which have really shown that when you have a pathway like that in place, most people with complex psychosis will do well. A case control study carried out in Ireland showed that people who had access to these kinds of services were 8 times more likely to be discharged from hospital successfully than people on a waiting list, and they also showed greater improvements in social and everyday functioning. We've carried out 2 big programmes of research nationally in England, one that focused on the inpatient component of the pathway called the REAL study, and one focusing on the supported accommodation part of the pathway called the QUEST study. In the REAL study, we found that 57% of people were successfully discharged from inpatient rehabilitation services to supported accommodation without relapse or readmission or the placement breaking down within 2 years. And another 14% were ready for discharge, but were awaiting a suitable vacancy in supported accommodation. So if you add that together, you get over 70% of people doing well within that kind of time frame. When we looked at the supported accommodation component of the pathway, we found that 38% of people progressed successfully from higher to lower supported accommodation over 2.5 years. We chose that time frame because a lot of supported accommodation services are commissioned to work with people for a limited time of about 2 years. And we can see from these data that actually that time limit is simply wrong. Most people did not progress within 2 years. A smaller study we carried out a few years ago just in North London looked at what happened over a 5-year period, and we found that 2/3 of people sustained their successful community discharge from hospital over that 5-year period. But it's noteworthy that only 10% achieve fully independent accommodation within a 5-year period. So in other words, 90% continue to need some form of support in the community. So those findings are really helpful in benchmarking the kinds of success rates we can expect when we get the organisation of services right. Those big programmes of research have also allowed us to look at the factors that are associated with people moving along the pathway in that forwards direction. From the real study, we've been able to identify that people who had better social skills and were more engaged in activities were more likely to progress. And from both studies, we found that the recovery orientation of the service, the degree to which the service operated with a recovery basis, as well as the degree to which it promoted people's human rights, were also associated with people doing better. Those aspects of human rights promotion and recovery orientation were assessed using a standardised measure that we developed in another pan-European study a few years ago. The measure is called the QUIRK, the Quality Indicator for Rehabilitative Care. And the manager of the service completes this measure online, and it gives them ratings of their service on 7 domains of care. And these 2 domains are the ones that we've found to be particularly associated with better outcomes. You can see the detail of the kinds of things that the measure taps into to give you a score on those domains. And that tool is freely available at www.quirk.eu for any service manager to use. There's a version for inpatient type services and a version for supported accommodation services. Those of you who are used to interpreting odds ratios will notice that the odds ratios here are quite low. We're only just scraping above 1. So these are not startling results at all. On the other hand, given the complexity of the problems that we're talking about for this particular service user group, these are indicators, they're kind of signals of the things that we should be focusing more attention on. So more recovery orientation, certainly promoting people's human rights, and finding ways to engage people in activities, particularly activities that promote social skills, seem to be important. One study that's looked at the cost benefits of providing rehabilitation services comes from colleagues in the UK. Mel Bunyan and her associates looked simply at the inpatient costs of 22 people who came into their inpatient rehabilitation unit, the costs before, the 2 years before they came to the rehabilitation service, during the rehabilitation, and 2 years after they left the unit. And you can see that the costs per year dropped from £66,000 to £18,000 per year before and after rehabilitation. But actually the cost of rehabilitation is quite expensive. Inpatient rehabilitation there was costing about £74,000 a year. So it's not a cheap intervention by any means. However, if you extrapolate that up on the basis of, say, 100 people, to make the maths simple, and look at a 10-year trajectory, 3 years before the rehab, 2 years in the rehab unit, and 5 years after the rehab, and you assume that our rates that we've found in those large programmes of about 2/3 doing well are correct, if you add up all the costs accordingly, the 67% who do well will cost about £30 million. The 33% who don't would cost £22 million, assuming they never left hospital, which is a vast underestimate because most actually will, but just not necessarily within 2 years. The total cost, therefore, for that group would be £52 million. But if you didn't have rehabilitation, you're talking about £66,000 per year for 100 people, which comes out at 66 million. So this is a very rough cost-benefit analysis. We don't have really good health economic analysis. There are some underway at the moment which are due for publication and will be coming through soon. But actually, even this shows you that the investment in rehabilitation is worth it because you're able to help the majority of people step down from more intensive to less intensive services over time. Another interesting finding is that staff who work in mental health rehabilitation services tend to have better morale than people working in other parts of the system. These data come from Sonia Johnson's survey of staff morale of mental health services across the NHS in England, and also from a smaller study where we repeated the same measures for people working in mental health supported accommodation services. And they show that measures of burnout and total exhaustion are lower amongst people in rehab and supported accommodation services. Working with colleagues here at ANU, we're beginning to look at the ways in which we might be able to investigate and interrogate these kinds of national data in more depth. This is an example of some work that's ongoing where some of the data from the Quest study have been used to see whether it's possible to understand more about the way a whole system might be working. This particular collaboration was looking at development of visual analytic approaches to make it easier for service planners to be able to interpret the data that we're getting from these kinds of studies. And this is a study that's been led here from ANU with Luis Salvador de Cruller and also Gina Chung. Here's an example of the kind of visual analytics that they're developing. This looks on the surface of it simply like a very pretty piece of artwork to me, but with some greater explanation. Each of these lines represents a particular supported accommodation service. The different colours represent different types of supported accommodation service that we surveyed and involved in our Quest programme. And each of the vertical lines on the x-axis is representing a different variable. And you can interrogate these data clicking onto these kinds of interactive faces to look at the range and also to be able to notice patterns. So you'll see that towards the right-hand side of this graph, you're getting a lot of lines that are much closer to each other. These variables are the scores on the quirk, on the quality indicator that I mentioned earlier. And so they're much more grouped together. Because this is a standardised measure and there's actually in that tool not a huge amount of variance between services. Whereas the variables to the left of the picture are much more descriptive variables, and you get a much greater range, for example, in length of stay or the number of places. So this kind of visual display allows you to be able to look closely at differences between services, but also to be able to pick out outliers much more easily than you can if you're just looking at lots of tables of data. And other methods that are also being developed here include being able to look at patterns in the data using hierarchical clustering. So here we're being able to look at the way in which the quirk domains of quality group together in different services. So you can see on the right some spiderweb type diagrams that show you the number of services that are showing similar scores on specific domains. And again, this allows you to pick out particular differences between services or service types, depending on what level within the hierarchy you want to investigate. And you can also choose the different variables that you want to look at within the hierarchical clustering. Now, despite all of this research and the evidence that these services are doing well, what we're finding, certainly in the UK, is that unfortunately there's been a lot of disinvestment in mental health rehabilitation services. Over the last 15 years, about 2/3 of NHS inpatient rehabilitation services report some form of disinvestment, and around half of all of them have actually been closed. There's been a shift in providing more supported accommodation, with clinical input being provided by community teams and an increase, in fact, in specialist community rehabilitation teams to do that work, all of which is very welcome. However, that hasn't avoided an expansion of inpatient rehabilitation service provision within the private sector. The hospital inspectorate in England and Wales is called the Care Quality Commission, and they've been inspecting all mental health services, both NHS and private providers, over the last few years. And they became quite alarmed at the high number of people they were finding in private sector, so-called locked rehabilitation units, often situated a long way from the person's home. They felt that often those kinds of services weren't actually providing anything very, very rehabilitative. And in fact, they went so far as to say that they felt that they were institutionalising people. Overall, they identified 5,000 rehabilitation beds in England and Wales, 50% of these in the private sector, at a total cost of over £500 million per year. And they noted that the length of stay and the cost of care of rehabilitation provided by the private sector was twice that of local NHS rehabilitation services. This has led to a lot of negative media attention. People are very concerned about this situation, and I'm pleased to say that there's beginning to be some movement to try and reverse this trend. However, it's not on mental health services are not alone in seeing this kind of situation. This graph I'm just showing you shows the reduction in NHS longer-term beds over the last 40 years or so. That's the green bars at the bottom of the chart. And that includes learning disability beds, and older people's beds, as well as mental health beds. And what you see that in the blue line are the number of privately owned longer stay beds in those three categories all grouped together. So what's obvious from that chart is that the number of long-term beds being provided by the private sector has far outstripped what the NHS was providing back in the 1970s. So it does seem as though there's been a kind of trans-institutionalisation process going on in the UK, and the idea that we're a de-institutionalised country is actually simply a myth. To move a bit broader now, beyond just the UK, this study I'm showing, produced by the WHO, was a survey of 25 European countries' longer-term mental health care facilities using a toolkit called the Quality Rights Toolkit. And basically, this is a very stark and rather depressing read, because what they found is that in these longer-term mental health facilities, there was an awful lot of poor care. A lot of staff seemed to have very little training in mental health and knowledge about the way to promote and protect people's human rights. There was certainly a lack of personalised approaches to mental health care, a lack of rehabilitative activities, and often nowhere for people to move on to. So they were often rather stuck in these longer term facilities with no hope of progressing into more independent settings. Now, some of the countries that were surveyed are countries that are at an earlier stage of developing community-based mental health care. But the ones that I've highlighted are countries where that's not the case, and actually many of those are high-income countries. So I think these findings are particularly worrying given those facts. In Italy, this study I'm just showing on the slide now also picks up on a similar theme. Italy is another country that's known for its high levels of deinstitutionalisation. But over the last decade or so, there have been increasing concerns about the expansion of private sector community residences for people with longer term and more complex mental health problems. These particular data come from Lombardy. And in Australia, you'll be perhaps familiar with data from the survey of high impact psychosis. Again, in Australia, a country with few inpatient services, where you've had an increasing reliance and partnerships with NGOs to provide community-based care, the SHIP survey suggested that actually people with more complex and longer-term problems were probably suboptimally treated, often getting too many medications or not being offered the right medications, not being offered the right psychosocial evidence-based interventions that we know can help, and having poor access to physical health care, high rates of social isolation, and increasingly problems with homelessness. So it does appear that this is an issue globally. And just to add to the problems, in the UK recently there's been a shift in the way that benefits are organised for people with long-term conditions, and data have shown that people with long-term mental health conditions have been more at risk, about 2.5 times more at risk of losing their benefit compared to people with physical health conditions. And I know you're very familiar with the particular barriers there might be for people accessing NDIS here in Australia. So all of these are problems that we now know about that lead to people with more complex needs being kind of marginalised. And so I thought it would be helpful for us to think about why is that happening. And I think one of the major reasons is that this group have been missing from policy in recent years. The last few decades have really focused a lot on public mental health promotion and early intervention for all sorts of mental health conditions. And there's nothing at all wrong with that. But the factors associated with developing more complex mental health needs are well known and are also probably not amenable to this kind of policy focus. For example, having some kind of perinatal brain injury, being male, being younger at the age of onset, having a more insidious onset to the development of psychosis, etc. These things don't really respond well to public mental health promotion initiatives. By definition, people who've got more complex needs are going to require a longer term and, I think, specialist approach. And that seems to undermine the aspirations of public health promotion and early intervention policymakers, who quite rightly think that if we can get in and help people at an earlier stage, we might be able to prevent longer-term problems. However, the long-term data that I showed you right at the beginning suggests that there continues to be this subset of people who are developing psychosis who develop long-term complex problems. And therefore, we need to think about that group as well as investing in public mental health promotion and early intervention. The other issue is that this group often don't really have much of a service user voice. As I mentioned, they might well have become estranged from family, and therefore family members may also not be there able to advocate for their needs. So they've become a little bit invisible. And the lack of acknowledgement in policy, I think, has been really highly detrimental, as evidenced by the data I've just shown you about the high levels of institutionalisation and trans-institutionalisation. The other issue is that service planners are often working under enormous stress, and there are a number of barriers in the way that services are planned that can get in the way of thinking about this group. Service planners will often be working to an annual financial cycle, a bottom line at the end of each financial year, rather than thinking about pathways that are supporting people across a decade or so. Economic constraints, of course, mean that the people often will think about what can I cut in order to bring my budget in on target. And rehabilitation type services are often the target, the victim of those kinds of knee-jerk reactions. Certain systems have kind of perverse incentives or ways in which financial structures make it more difficult for systems to hold on to their longer term services, but also can force service planners to think about cost shunting to other parts of the system. In the UK, for example, NHS trusts who are providing rehabilitation services were able to cut those services, and those people with longer term needs are now funded through a different pot through the local commissioning bodies. And so the NHS trusts don't really see a direct problem in terms of having cut those services. Of course, the problem is for the individual. This all leads to rather a poor and fragmented oversight of this whole system approach that I talked about at the beginning, and this need for a longer term pathway. And the impact of all of that is that if you cut your specialist rehabilitation services, then you don't have any rehabilitation skills or expertise. That means people don't get the right treatment. That means they're more likely to stay in hospital too long or to be moved out to some other form of institution. And the principles that we all try to work to of treating people as close to home and in as least restrictive environment as possible are undermined. And that's why, a few years ago, I wrote a document for the European Commission with Professor José Miguel Caldas de Almeida that talked about the importance of including plans for this group in any kind of deinstitutionalisation programme alongside all the other things that you would need when you're thinking about developing community-based care. But in order to do that, you need enough money. Data that a colleague of mine, Tatiana Taylor, produced, taken from 171 longer-term facilities across 8 European countries involving nearly 1,500 service users, allowed her to model the association between a country's spend on mental health and the quality of longer-term care. And what she found was that there was a positive association with the percentage of the national health budget that was spent on mental health and service users, autonomy and satisfaction, as well as quality of longer-term care. And she went on to show that actually if the percentage spend on mental health that a country spends was around 10%, the quality of longer-term care was able to increase above the pan-European average across all countries. So in other words, there appears to be a kind of threshold amount that countries need to invest in mental health to have this trickle-down effect, even down to these longer-term facilities that are there for a relatively small proportion of those with mental health problems. But actually, the reality is that very few countries spend anything like 10% on mental health. The average is about 2.8% globally. So the key drivers that we need to deliver a whole system approach to mental health rehabilitation include, first of all, supportive policy, principles of service planning that get around these issues that are obstructing whole system pathways, These things can be very much supported if we have clinical guidelines telling service planners and commissioners what to commission locally, and a real sign up to integrated systems where we have health, social care and voluntary sector services working well together. So I'm pleased to say that there is some hope in all of this, that the first of these key drivers, policy, seems to be taking note of these kinds of situations and these kinds of problems. The latest NHS policy in England, the long-term plan, has specifically talked about integrated models of care and maintaining and developing services for those with the most complex needs. And in fact, there is now a national initiative to encourage local development of rehabilitation services to try and reverse this trend of the out of area, out of sight, out of mind problems that I've illustrated. Excuse me. In Australia, there is some work going on in New South Wales to think particularly about the longer term group. The Pathways to Community Living Initiative have been doing some thinking and planning around that for the last few years. There are also some important groups who are beginning to drive momentum broadly across the country as well. The Royal College now has a section of social, cultural and rehabilitation psychiatry. And there's also an Australian section of the World Association for Psychosocial Rehabilitation. So it seems as though people are kind of rediscovering or noticing that it's important to be thinking about this group and thinking about mental health rehabilitation services for those with more complex problems. The service planning principles that I think we need to sign up to are, first of all, an acknowledgement that we need local rehabilitation services for this group. Local may mean different things in different countries. I'm very aware that local means something different in London than it might mean in outback Australia. Rehabilitation does take time, so those service plans need to be plans that go over a number of years, usually at least a decade for an individual. And that might mean that we have to adjust procurement cycles for services. So instead of changing contracts every 1 or 2 years, we're thinking about services being procured for more like 5 to 10 years to be able to support people through the whole process of rehabilitation and recovery, rather than having discontinuation and changes in providers. Those perverse financial structures I mentioned really need to be addressed in order to avoid these negative outcomes for individuals. And I'm just sort of reminding you really of that graph about the way that knee-jerk responses to cutting services can have unintended consequences due to market forces. Where the NHS has cut services, the private sector has just stepped in and proliferated, and that's an unhelpful use of public money. And I think service planners also just need to be wary of fashionable trends. It's often the case that people will talk about a new model of care and everyone will start saying that's the way to go. But actually, what we've found is that we need both inpatient and community-based services to be able to provide the right sorts of inputs for this group to support people to achieve their maximum, their optimum functioning. Clinical guidelines are very helpful levers. In England and Wales, commissioners are accountable for contracting services to deliver the treatments and interventions that are recommended by NICE, the National Institute for Health and Care Excellence, and service providers are responsible for delivering these. And if those things are not in place, then people, commissioners and providers can be challenged about that. So if there are threats to existing services, having NICE guidelines in place allows you to challenge that much more successfully than if there are no NICE guidelines saying that you should have these services. And so it's good news that this year the first NICE guideline for mental health rehabilitation will be published. It's focusing particularly on people with a primary diagnosis of psychosis who also have severe symptoms that are not responding well to treatments, comorbid conditions such as those that I described at the beginning of this talk, and difficulties with everyday functioning. Out of scope are people with other primary diagnoses, but of course those other problems may well exist as comorbidities. I can't tell you about the detail of what's in it because it's not published yet, but I can tell you that it covers things like identifying the people who are most likely to benefit from mental health rehabilitation services, the way services can think about their organisation and structure, how to deliver optimised treatments for people who have these particular problems, There's a big focus on recovery-based approaches, collaborative care planning, and improving the service user and carer experience. There's also a lot about the therapeutic programs that are very specific to rehabilitation, particularly things that are about helping people with function and with improving physical health. There's also evidence and recommendations about different types of supported accommodation and the features of supported accommodation that are most likely to help people live successfully in the community. And also there's evidence and recommendations about how people transition in and out of rehabilitation services. So the fourth key driver is the integration of the different components and different providers of those components. Integrated care systems are very much in fashion in England. The idea is that there's a sign up locally for all the resources that exist in a local catchment area to come together to be able to support the needs of a particular community. Now, mental health services are quite advanced in this compared to, say, physical health services. And at the organisational level, it's about having a shared vision or strategy and sharing resources, sharing budgets, having financial risk shares and things, all of which are really helpful at making people work well together. If you're sharing financial risk, you tend to listen very carefully to the decisions that you will make. At the service level, though, it's not entirely clear quite what an integrated care system is. But what seems to be happening and evolving is that the operators, the providers of services are having to work closely to be clear about their remits and responsibilities. And that involves often having lots of meetings to make sure that they're not stepping on each other's toes or duplicating work, and that they're continuing to hold this shared vision. It also helps people really address those financial structures that are unhelpful. Now, I mentioned that service planners needed to be wary of fashionable trends, and here's an example of an integrated rehabilitation service model in Camden, a place called Tile House. This was an innovative partnership between the NHS statutory and non-statutory services, a housing association that provided 12 individual self-contained 24-hour staffed flats with building and support staff on site provided by the Housing Association, and then the clinical input also on site provided by the NHS Local Mental Health Trust. So clients have a tenancy and pay their rent through housing benefit, and the clinical staff continue to be employed by the trust, and that protects all of their employment rights. There are benefits to that kind of model, and we're seeing a proliferation of those sorts of integrated models across England. It certainly promotes common values and language. There are certainly complementary staff skills and strengths and shared learning that comes from it. And it allows really, I think, a much more inclusive and collaborative approach when working with service users together in this way. And it certainly has helped us enable some people who've been in hospital for a very long time to come out of hospital and to live in the community. And the whole project was in fact funded partly by the financial flows that came alongside that. But there are challenges. So, for example, who gets to decide whether or not someone is appropriate for that service? Is it the housing provider or is it the clinical team? And this is sort of acted out sometimes in tensions between the two, particularly in thinking about how you might work with someone who's showing challenging behaviour, or in deciding whose role it is to do something or other. So those sorts of tensions do seem to be quite common. And there can also just be practical issues. For example, the clinical staff having access to their electronic notes. That took 2 or 3 years to sort out, so they kept having to go off-site to make entries into their NHS records. They also talked about it feeling quite isolating, that they didn't feel like they were necessarily part of a team, and they really missed that support of the MDT that they'd had previously. It's quite an expensive model as well, and it hasn't been a success for everyone. It's been quite difficult for people to move on from such a specialist setting to less supported accommodation, and a number of people have relapsed. So the jury is out really on whether that provides a good alternative to more standard supported accommodation. Other approaches are where you keep the two separate. and you have a clinical team with specialist rehabilitative skills who are providing the clinical input into supported accommodation. So this is the model that we operate in the area that I work. So we care coordinate and have the statutory responsibilities to work with people who have been in hospital and who are subject to our framework called the care programme approach. That allows us to be very proactive in engaging with people who are coming into supported accommodation services from inpatient and forensic services. And it also means that we're going into supported accommodation services a lot, so we see a lot, we're able to talk with staff a lot, and we're doing in vivo work, which I think is really very valuable for people with very complex needs. And it also allows us to meet with carers outside of clinical settings. There's also a big role in liaising with primary care because of the high levels of physical health comorbidity. And the whole aim of this team is really to work with people so that they can step down to lower supported accommodation over time. So I'm coming to an end. Just to summarise, really, I just wanted to reinforce a few points. I think enabling recovery for this group of people who have very complex psychosis really does require a whole system approach. That needs to include, first of all, adequate financial investment in mental health services. Secondly, an acknowledgement in policy and in local policy of the fact that some people will have and will continue to have complex needs. A commitment, therefore, to provide adequate and appropriate longer-term services that can support people's recovery. And I think that that does involve both inpatient and community-based services. And those services should be provided across providers, health, social care and voluntary sector, working well together. And I think we're beginning to understand more about the ways in which those different components can work better together. Of course, they need to be staffed by people who are committed to this work, who like this work, and who are trained and supervised to be very much recovery oriented in their approach. And that everyone from policymakers down to frontline staff remains hypervigilant to avoid the mistakes of the past that lead to people becoming institutionalised and marginalised again. So finally, it's just really a sort of aide-memoire this for people who whose recovery path is a little bit more complex than the average. We really do need to hold on to that long-term view. Thank you very much for listening. Okay. Yep. I'm just being guided on what to do with the tech now. Okay. So we should have, I think, I'm hoping that some of you will have been perhaps sending in some questions to us. We're just trying to find the bit of the tech that gives us the questions you might have sent in. No, perhaps there aren't any. It may be that there aren't. No. Okay, that's all right. If people do have comments, feel free to send some in now. We'll keep checking on that. And alternatively, you can send them in, I think, for a little while the webinar is still open, should there be any that you want answered. Yes?
Helen, can I ask an offside question?
Yes.
We have a problem with cohort management. So we have a younger group that are quite complex, and then we have our older group. How do you manage that in the UK? Do you have separate services?
Yes. So I hope everyone heard that. The question was about whether for this complex and people with complex needs, that you may well find a situation where you have an older group and also a younger group. So we do have some specialist services for people over 55 or people who have more physical health frailty than the younger group. For some of the people who are in the older group, we had a cohort of people who had been in the older, very long stay wards before the period of deinstitutionalisation. And so that group did need something a little bit more specialist for a while. But actually, the majority of that group also progressed outside of the hospital setting. So I think where we've made a difference is where people have a lot of physical health needs, are quite frail, and then they need a little bit more of the kind of nursing and personal care input than somebody who is, you know, higher functioning and younger. And so we've got some specialist services for those individuals, but it's actually a very small number now. Mm-hmm. So we've been able to scale that down over the years.
Thank you.
Aha. So there's a comment here. Thanks very much indeed. And thank you for your compliments about the talk. That's very nice of you. So your question here is, how do you develop rehabilitation teams that respect both clinical and psychosocial skills? I'm not sure that I necessarily fully understand the question, because I think where I work, there is a very much a biopsychosocial approach. So we are thinking all the time about different aspects of somebody's problems that we may need to assess and identify in order to attend. We have quite a sort of, I'd call it a flattened hierarchy in our MDT culture. That doesn't mean you don't have clinical leadership. You have a consultant psychiatrist and a team manager. The team manager will be a clinician as well. But there's a regular team meeting where we will all get together and discuss whatever the particular issues are that a clinician might be facing with an individual. I think probably where I experience more of that interface about how do you get equality going between clinicians and non-clinicians would be in this interface between our clinical team, for example, and supported housing staff. And I mean, what's interesting to me, both from the research that we've done, but also the clinical work, is that the staff working in supported accommodation are, to my mind, incredibly refreshing, because they haven't got a clinical training. So they're coming at the work that they're doing with a completely different head-on. They're thinking about the person's social needs primarily, and we are tasked with attending to their clinical needs. And of course, we have to have conversations and share care plan and approaches to make sure that we're all doing the right stuff. But it can be very helpful to hear from a support worker who has already got an incredibly good knowledge of the local resources in the area, and how they've thought creatively about how to get that person out and about in the community, for example. So I think it's just about how do you create respect? Well, you come with respect. You respect each other's skill sets, and you try to make sure that there are forums for discussing everything that's going on for the person. We have a regular clinical review for every client for an hour in the community, and when people are in supported accommodation, that big meeting happens every 6 months. And in between time, their care coordinator will be seeing them and talking with the support staff in the supported accommodation every week or 2 weeks. So there are plenty of points at which difficulties can be flagged and conversations can be had. And I think it just comes down to that. It's about listening and trying to come up with plans. And if you get somebody who's got a very strong opinion about something and you're entering into a disagreement, yeah, you may need to take that away and have a separate meeting about that. But I haven't really had that happen, I have to admit. The next comment is, could we have the PowerPoint to review later? And the answer to that, yes, it's going to be made available through the Centre of Mental Health Research. How do people get it? Do they log into the same place they logged into the webinar?
Yes, we will send it.
We'll send out some information about it. We'll either send it out or send information as to how you can get it. And I see that somebody's, I think it's the same comment, that NGO and psychosocial services are not attached to clinical leadership here in Australia. So I guess my question then is, are you saying that the clinical team sitting separately from the NGO and the psychosocial providers are clashing, that you're finding that there's a big chasm? Is that what you're saying, that it's not easy to have those joined up conversations? I'll wait for your answer. Scrolling down a bit. Okay. I've got another comment here. Yes, this is the answer to that last question. I thought so. So it's about forums. I think it's about forums. It's about making the space. So this in-reach, the fact that we do the work in vivo, means that we go into the supported accommodation service. We have a meeting together with the supported accommodation staff and the service user, and we all talk together. And actually, when you're all talking together, people tend to behave better. It becomes simpler than people sending, irate emails to each other. I'm not saying it's easy, but I think that you just have to have enough forums and go with a listening ear. And challenge, if you see people behaving in a way that you think isn't professional, where you're not being listened to, then actually you have to challenge that, and you may need support to do so. There's another question here, which is, do you have any good examples of dual disability services? What does that look like? What does that MDT look like? I'm not sure if I know what you mean by dual disability, because what I'm talking about here are people who've all got more than one problem. So they'll all have, treatment-resistant symptoms, but also some other comorbidities. Whether we mean substance misuse and mental health, is that?
I think it would be intellectual disabilities.
Okay, right. Intellectual disability services are a specialty in the UK, at least. So there are specialist community teams that are staffed with people from social care and from clinical services. And they provide the same kind of function that I was talking about with the community rehabilitation team, but for people with a known intellectual disability. But of course, many of the group that we're working with in rehabilitation services have a low IQ, an intellectual disability either that was on the borderline at the point of developing psychosis, or that has come because of the psychosis as the person's cognitive function has declined. So we do use some approaches that are the same as in intellectual disability, thinking about language and easy read, being able to communicate with people, getting staff to explain things in particular ways for people who may have difficulties with comprehension. But they are effectively more or less separate. There's another comment here. Would individual or group psychological therapy be a part of your view of rehabilitation in the inpatient and or the community setting? Absolutely. Psychological therapies are all part of the complement of evidence-based interventions that we want to be able to offer people. So the psychologist I mentioned is another key member of the team, and they will be delivering psychological interventions, but sometimes when somebody's very unwell, they're just not well enough to engage in a classic manualised programme of CBT. So the work might simply be about working with the individual, but also working with the rest of the team to find the things that are going to engage that person in wanting to get out of bed. And sometimes, for example, you have to deal with other problems before you can get into the CBT for psychosis work. So it might be that the thing that is actually most disabling is anxiety or OCD symptoms. And those are what the psychologist really needs to sort of focus on. They'll be doing that work, but they'll also be finding ways for the rest of the team to reinforce the work, because in any of our teams, we might have, if we're lucky, a 0.4 or 0.5 psychologist for 150 clients. So clearly they can't see every single client who needs a psychologist. So it's important that all the team are fairly familiar with those slightly less specialist psychological interventions. Yep, there's some more questions coming. Thank you again. People are saying this was an enjoyable presentation. That's my first one of these, so thank you very much for the feedback. What are the possible advantages or disadvantages of having strong psychopathic traits? Oh gosh, well, I don't know if I can answer that, because I think it could get into a very political discussion about the psychopathy of our leaders in politics. But all I can say really about psychopathy in complex psychosis is that it would be a comorbidity, and it's possible, I should say rather than likely, that some of the people who come to us who've been in forensic settings may well also have underlying antisocial personality problems. And those are things that, of course, we have to be mindful in terms of all of our decisions about how we work with that person, and also try to help them reflect and try to avoid the same mistakes that they might have made in the past. It's a kind of challenging behaviour, and it of course can be very difficult to treat. There's another question here. How do we calculate where to strike a balance between inpatient and community components? Of course it would be locally relevant, but is there a formula guideline? Well, if only there was. No, there isn't, and that's why you need to look at it locally. So in the NICE guideline that will be coming out, there's a suggestion of something we call a joint strategic needs assessment, which is something that all localities do in England. And that's based on epidemiological data and service data. So in other words, you're trying to understand the context within which you live and provide services. And so you need data on the local morbidity and obviously the prevalence of different mental health problems in order to be able to extrapolate and estimate the number of people with complex psychosis who might need specialist services. And you also need to know what services you've got in place. So it's rarely the case that you're building something completely from scratch. Most places have something. And of course you have to think about how you might adapt that according to your population needs to be able to provide some of this specialist approach. It's easier in more populous areas, of course, where you'll have more resources. Another comment here is any tips on advocating for the kinds of systemic reforms you're talking about in the current political environment? Well, all I can say is that I feel as though I've been saying this stuff for about 20 years, and it's taken 20 years for us to get to the point where we've got rehabilitation and the needs of those with complex problems into NHS mental health policy. We've got a national programme going, and we've got a NICE guideline coming out. So it's been a long haul. I don't think it needs to take that long in every country. I hope that what the UK is beginning to do, that momentum we're seeing, is being picked up elsewhere, and I feel that it is being picked up here in Australia. Certainly it seems to be clearly being picked up in New South Wales. I think there's good work that I'm hearing about here in ACT as well. So I think that people are realising that if you don't plan and have the right services for this group, actually, A, you're doing them a terrible disservice, but B, it's very expensive. So I think in many ways the case is quite simple, but it's getting people to hear that. And I think that's where we could really benefit from more service user voice and more carer advocacy, and being able to tap into people who have experienced these kinds of marginalising situations, I think is often a very powerful way of engaging the ear of policymakers. A comment on the challenges of those with complex psychosis having a voice in services, says another commentator. How are carers and consumers' voices incorporated? Well, it's really difficult, because if you are working with people who are very unwell, who may not be very keen on engaging with you at the beginning of their recovery, and who don't want you to have contact with their family, it can be very difficult to ensure that their voice is heard. I think really it boils down to having all of the people who are working in these services being kind of run through with a recovery training. I challenge myself, my team all the time in the decisions that we make about whether or not we are being truly collaborative. And at times, you know, you can't engage somebody to have a really shared conversation about the next steps. But actually, it's not really for very long that someone is at that stage usually. Quite often we can move from someone being very disengaged to them beginning to meet us a little bit. And any signs of the person being able to kind of work with us, of course, we will try to build on. So I think at a microscopic level, helping somebody decide, what they want to eat, that's a recovery-based approach. Helping them choose food, helping them decide, if they want to come and watch something on TV, that's a recovery-based approach. So I'm not talking about sort of grandiose plans of a full recovery plan that's going to get them back into full-time employment from day one. we're talking about all those tiny incremental steps that take many years sometimes to get the person being, you know, enabled and re-empowered. So.
Next.
Okay. Now the next one is the next question. Oh, it's hello, Alan. It's Alan Rosen from Sydney who said, "I've managed to do a whole talk without mentioning ACT, assertive community treatment.
Oh.
What is the current status and prospect in the UK and Europe?" Hello, Alan. So I haven't mentioned ACT. ACT, I'm sure many of you will know, is a specific intensive form of case management, a kind of model of case management and shared case management. Started in America, also rolled out here, and then rolled out in the UK. In the UK, ACT has completely disappeared. It's been a sort of victim of, I think, of economic constraints and interpretation of evidence in a short-sighted way, I guess I can put it like that. We carried out a big trial comparing outcomes for people with complex needs who were receiving ACT versus people receiving standard community mental health team care. And basically there were no significant advantages for the ACT group, except that they preferred ACT to standard care and they were more engaged with it, therefore. And on the basis of that one trial, unfortunately, the whole of the ACT programme in the UK was disinvested. In other parts of Europe, ACT has been implemented. Some Scandinavian countries have implemented it fully or in certain areas, but increasingly more sort of hybrid models of ACT are being implemented, things called flexible ACT, and there are other forms of hybrid ACT that's a sort of halfway house between standard CMHT care and a more intensive approach. I think that the community rehabilitation team approaches that I described very briefly today incorporate some of the key features of ACT. That's a tight team, a team who know the clients of the team. They all know all the clients, where you talk about the clients a lot, where you have a lot of reflective practice and you do as much of your work as you can possibly do, ideally all of it in vivo in the person's home or supported accommodation service. They're not extended hours services though, which is another feature of ACT. So I think something like ACT is probably on the up in Europe, but not so much in the UK. Community rehabilitation teams that are a bit like that are on the up in the UK. So there'll be certainly overlap. If we were to measure fidelity of all of these things, there'll be features in common for sure. Okay, another question is, given the prevalence of physical ill health amongst people with severe mental illness, how do we engage GPs as part of rehabilitation, as part of the team? I can't sort of go into the details that's in the NICE guideline, but there's an awful lot in the NICE guideline about exactly this, so do keep an eye out for that. But to give you some examples, some of our teams have a physical health trained professional who may be a physical health nurse who's also a mental health nurse, or just a physical health nurse, whose job it is to particularly try and liaise with primary care and also to potentially do some of the monitoring assessments for people who find it very difficult to visit their GP. And that works quite well. I mean, GPs vary in how willing they are to be liaised with, in my experience. So some of them are very happy and are on the email all the time, and we have a very easy communication. Others are a bit more standoffish. So I think it comes down to developing personal relationships, visiting, again, that thing about if you meet people in person, they tend to be, you know, happier when you email them than if they don't really know who you are. And it's an ongoing struggle. We've got around it for some people in terms of the routine blood tests and ECGs that we would like to do for individuals on complex medication regimes by having those done through our clozapine clinic service. And that works really well. And then the difficulty comes if there's an abnormal result, because of course, you know, you need to communicate that with the GP. But actually, these physical health matrons or physical health nurses who we have working with us now are doing an excellent job in really kind of breaking down those interface barriers that we were struggling with. So that's a good investment in my view. Another question, do you find any difficulties working with acute inpatient care services in terms of continuity of care if people have an acute admission? Well, yes is the short answer. When somebody's admitted in our system, I don't know how it is here, but in our system, if somebody has an admission, I don't know which ward they're going to. Even if I found out which ward they're going to, it's likely they will move 2 or 3 times within the first 2 or 3 days because of bed management issues. So it can get really complicated to try and talk to the clinical team who are going to make decisions. We try and do as much communication as we can through electronic records. So we'll write a plan, you know, what's the point of this admission, why are we admitting this person, what is it we want the inpatient care team to do. And then the key person is the care coordinator, because they will go in and see the person the next day and every few days. And liaise with the inpatient team to share information and also to reinforce the plan that we have been thinking of in the community. And of course, we pick up the phone and try and have conversations where we need to as well. There's another question from Sydney. Is it true that the strongest evidence for a component of inpatient care in balance with community care is in rehab of complex psychosis? In most other psychiatric care, including most acute services, wherever studies done, they usually favour community alternatives. No, I'm not saying that. I guess I think the question is saying, I'm advocating that having a whole system pathway for people with very complex psychosis, complex mental health needs, should include provision of inpatient services. And the reason I advocate for that is because we see that when people don't have access to that, they bounce around the acute system for 10 years or more and having recurrent admissions, not being stabilised, not getting what they need to be able to live successfully in the community without further readmissions. So they often need a period of very focused, expensive, intensive assessment and treatment to be able to stabilise things and then leave hospital at the earliest opportunity. So that's why I personally think that we need both. I think that it's very difficult, impossible, into my mind, to do some of the things that we have had to do to stabilise some of our most complex folk in the community. We simply couldn't have done it. We've done some really complicated things in the community, and we've pulled out all the stops and had our clinical team surrounding the person, I don't mean literally, but you know, going in 2 or 3 times a day, sometimes to a 24-hour supported accommodation service to try and instigate certain treatments and to try and keep the person safe and away from the inpatient ward. And it's incredibly laborious and not always successful. So I think actually it's better for everyone to have a period of treatment in hospital where it's needed. This pathway I'm talking about isn't a sausage factory. You don't have to step through every single point. Of course, you can join that pathway at any point. You don't have to have inpatient care before you get your community care. You can go straight into supported accommodation if that's possible. But most of the economic analyses actually show that there is no difference in costs. Yes, inpatient care is more expensive, but if you invest in community-based care that's adequate for a community, you need to invest a similar amount. And the Thornycroft balanced care model, the Tansel and Thornycroft balanced care model, is all about the fact that you can't replace every single inpatient bed with community services. You will continue to need inpatient beds. So that's why I refer to that balanced care model. It makes sense across the system, but it also makes sense particularly for this group. One further comment here. Please, could you comment on the ideal number of mental health rehabilitation beds per 100,000 population? And what would you suggest would be a good size of a mental health rehabilitation unit? Well, I can't answer the first question because it depends on your locality, it depends on your context, it depends on your morbidity, it depends on how many people you've got with complex needs, it depends what other services you've got in your area. So there is no one figure. In terms of what's a good size for a mental health rehabilitation unit, well, there's a critical size, which I can't tell you what that is either, but it's not too big and not too small. So if it's too small, it becomes economically inefficient. If it's too big, you run into the problems of institutionalised types of care. So on average, an inpatient rehab unit in the UK would have somewhere between sort of 14 or 16 beds, that sort of size. And supported accommodation services, staffed residential care homes tend to be about 12 to 15 beds. supported housing, 24-hour supported apartments, usually again kind of 10 to 12 max in one site. And then our visiting floating outreach services, they will work with a much larger group of clients because those clients are living independently, but with the floating outreach team visiting them. So they'll have caseloads of 30 or 40, sometimes much bigger. What do I see as the strengths of the PCLI initiative in New South Wales? Well, first of all, that it's been something which has been supported at the highest level, at the ministry level. It's had money attached to it. It's been very carefully thought out. It's involved detailed assessments of people who've been in long-term care for many, many years, very individualised care planning and thinking about what those people may need when they move out of longer stay settings. So it's been a very carefully constructed and very well conducted piece of work in my view. And I think it's laid the path for the knowledge that people with complex needs continue to come into the system. So although PCLI was about the kind of older long stay population, it's become apparent, and it is apparent from everything I've said, that we need to continue to have those sorts of pathways for the newer cohorts of people with complex needs. So I think it's already laid the basis for ongoing pathways like this in New South Wales. Another comment, I referred to 20% of admissions coming from forensic backgrounds. Do I have a view on the support of those involved with the criminal justice system and services in prisons and transitions to the community? Well, I think, my specialism is with people with complex psychosis, particularly complex mental health needs. And so there's a whole huge cohort of people who are involved with secure services who don't have complex needs. And they, in our system, they start off usually in the forensic system and then they would graduate to standard community mental health care or primary care. So I don't have anything much to say about them. The people who come to our system are exactly the same as the other people who haven't got a forensic background. They often have exactly the same sorts of needs. They've just been unlucky enough to get involved in some kind of criminal activity and ended up going through the criminal justice system. In fact, as I say unlucky, sometimes it's lucky because sometimes it's the route to accessing appropriate care. And quite often when you map the person's story, you can see that a lot of their criminal activity was clearly associated with their mental health problems and periods of severe unwellness. So they don't operate completely separately for that group with the complex needs. They will come through into the rehab pathway in the same way as someone without a forensic service. If we have a client who is imprisoned, who gets into trouble and goes into prison, we try to in-reach as much as we can. It depends where they go to prison. I thought that acute inpatient services were difficult in terms of moving people around. Prisons are much worse. You never know where anybody is from one day to the next, so it can be really difficult to keep tabs on someone. There are prison in-reach services as well, and mental health services within prison, so we try to liaise with the relevant mental health service and try to keep tabs on when they're coming out so that we can get involved again when they come out of prison. But it's really very difficult. Okay. Okay.
Any other questions?
I will answer that last comment about the one about the psychiatrist in Tile House. It isn't a typo. The psychiatrist in Tile House is 0.025, tiny amount of psychiatrist time. Okay. Yeah. I think there's one more comment. Okay, I think this is the last comment. Yes, thank you. This is just a comment saying that needing inpatient rehabilitation beds has been really supported by that graph that shows the exponential rise in the private sector. Absolutely. That's the strongest case I can make, really. So, thank you very much for all those questions. Really good.
Thank you very much. Helen, it has been really enlightening, and I think it was a perfect starting conference for this series in spite of coronavirus and all the problems we are having. You mentioned the tension between public mental health promotion and early intervention and the needs of people with severe and complex mental problems. And I think we can take it. We can try to prepare one of the next series on this topic on public mental health promotion and early intervention. And I would like to thank the audience and the participation, as well as the collaboration by the Office of Mental Health and Wellbeing in ACT, and the really extraordinary cooperation that we have had from Elizabeth Moore in these developments. So thank you very much, everyone. And we really hope that you will participate in our next event, probably in October. Thank you.